Good morning, good afternoon, good evening, everybody who joined from all over the world. I'm so sorry. We apologize for the delay. Uh, I'm Shavni, co-founder of Superstars Child Research and Development Center. We are honored to host this special webinar at Superstars, where we don't just provide therapy, we create a movement of hope and progress for neurodiverse children and their families. Our center is rooted in compassion, innovation, and world-class expertise. With a multidisciplinary team led by internationally recognized clinicians, we are redefining what's possible in pediatric developmental care. This webinar also launches our new weekly expert series that is part of Superstar Parents Awareness and Advocacy Program, where we still host conversations designed to empower parents with knowledge to understand how to identify the triggering factors in their kids. A heartfelt thank you to Dr. Vivek Jagani, a leading periodontist who, despite a demanding schedule while visiting the US for a professional conference, graciously accepted our invitation to speak with families at our center. Dr. Jogani was recently recognized as a highly commended periodontist of the year 2025, a prestigious honor that reflects his outstanding contribution to pediatric dental care. His deep expertise in oral motor development brings invaluable insight, especially for parents of children with autism navigating feeding challenges. Dr. Jogani will be joined by Dr. Samraj Gaddam, our clinical director and globally respected pediatric occupational therapist with decades of experience in sensory integration and feeding therapy. Dr. Gaddam has transformed the lives of countless children and families. Today, together, we will delve into root causes of feeding difficulties and share practical, parent-friendly strategies that can make a long-lasting difference. We extend our deepest gratitude to Dr. Jagani for his generosity, excellence, and continued commitment to advancing care of children. We are excited for the powerful conversations this series will inspire. I'm heading, I'm transferring this floor to Dr. Gaddam. He will take it off from here. Thank you.
You're visible, sir. You can talk. Where is my screen, sir?
Here is it. I don't get it. You want me to maximize the screen?
No. Good morning, everyone, and it's a pleasure for me to actually be on this along with Dr. Vivek. Vivek, thank you so much for joining us for this talk and giving me your precious time. Uh, and I hope the journey keeps continuing with you for many more years with your expertise in this area. Well, the topic what we have taken for today is on the feeding challenges, and probably it makes a lot of sense for me to make Vivek join this webinar, because most of the times when we talk about feeding challenges as parents, we just look at the act of feeding, but from a superstar's perspective, or from our research institute's perspective, we are looking at feeding not just as an act, but feeding as a part of what it means for a child and what would be the environmental factors which would be affecting, and just not how the child eats. It's more to do in terms of what all factors actually can influence the feeding. Dr. Vivek, we are going to talk today things concerning not just, as I mentioned, not just about I one second. I need to keep admitting.
No, not really.
Yeah, we are going to talk about this is going to be a series of webinar on feeding. Maybe we'll have 2 or 3 sessions going on this particular topic, where we are going to deeply talk about what would be the gastrointestinal concerns and how the positioning matters when you actually make a child eat, and what would be the fine motor and gross motor skills. And most of the time, how does this primitive reflexes or the advanced equilibrium and postural reflexes would impact feeding as such. And it's not just about that, it's going to be more in terms of the orofacial concerns, which could be, which in itself, once which in itself could be a big limiting factor in children, and the sensory processing issues like sensitivities, avoidance, registration, or seeking behaviors. And apart from that, how do you actually look in terms of how to draw a line or understand the behavioral outcome between identifying what is the issue behind the behavior as a functionality? Is it the sensory processing concern, or whether there are any other functionalities associated to that? And not just that, we will be dwelling more about what could be the parental feeding behaviors too. So Dr. Vivek would take us to talking about the impact of orofacial concerns. Dr. Vivek, I think you can start off in making us understand like what it means to have a good muscle tone, what it means to have good jaw control, what it means to have uh, the proper tongue placements, and other issues related to that.
Yeah, so good morning, everyone. Thank you, Dr. Samraj, for having me over today. More importantly, thank you for helping me fight the jet lag with this odd hours of uh, talk today. So excuse me if I just doze off in between, but I'm sure we're going to do justice to the time each parent is here to, understand more about the feeding uh, errors. So here, why orofacial evaluation? So as Dr. Samraj has rightly pointed out that, whether it's a behavioral pattern, a seeking pattern, or any neurological underlying developmental pattern, we also need to identify whether there is any structural fault associated with the orofacial structures involved or not, because with the structure, that is with the anatomy, the function may get affected, and many a times, um, without any structural evaluation, without any dental evaluation, it is more so based on the neurological point of view, and you don't get the answers, you don't get the right pattern why the child has the difficulty in feeding. Now, as and when we go, I may have overlapping of data with respect to each of the evaluation factors that you see on the slide for the orofacial evaluation. That is the evaluation of the face, the jaws, teeth, dentition, head and neck, lips, tongue, and pharynx, soft and the hard palate, and finally the symmetry and its functionality at rest. So each is taken individually, but most of them have their overlapping roles while evaluating and its implications on the development. So, when we talk about the evaluation of the evaluation of the face does not start when the child is on the dental chair. The evaluation of the face starts as the child walks into our operatory, whether it's Dr. Samraj's S.T.A.R.S setup or the pediatric dental clinic kids and teens across in Mumbai, India. So the primary evaluation starts immediately once the child enters our operatory, enters our reception, and that's where our evaluation starts. And the first thing that we identify is whether the child has an excited face or a blank facial expression, or it could be, just with the lips apart, with hunching of the back, so leading more towards mouth breathing associations and all those things. Now, when the child is in the dental chair, usually the parents are asked, or the parents come up with the complaints that the child has difficulty in eating patterns. This could be the child could be a picky eater, or a food pocketing, or a food pouching, takes a lot of time to eat. The child could be a unilateral chewer, that is, he may be eating only with one side of the dentition and not the other side. There could also be conditions associated with swallowing, that is, it gets difficult for the child to swallow. So the child may have preference to, a puree diet, or maybe a hard, crunchy, crispy diet. Some kids have difficulty in swallowing with a straw. Some kids may have difficulty just taking a sip of water or any liquid. When we evaluate the jaws and the teeth, this is a very strong association wherein we see something called as the functional matrix component. Now, it's very important for each parent to identify what is a functional matrix component. Functional matrix component, in simple terms, if we are here to discuss, it means form follows function. So, if the if a particular organ is put to function, the form develops, and vice versa. So, as simple, if you go to the gym, if you have to have the biceps developed, you need to make the flexion of the arms with the dumbbells, and that's how you develop the biceps muscles. So, only when the child is utilizing a particular component of the orofacial pattern, that area will start developing, may it be the lips, the tongues, the face, or the jaws and the teeth. Second important factor that we see is the dentition. When visiting the dentist, it's always, it hits everyone's mind, including most of the dental professionals across the world, general dental professionals, I mean, is the child would have visited for some kind of cavity or some kind of pain with respect to the tooth, maybe eruption or teething, or a tooth involving the nerve involved, so maybe needing some dental intervention. But here we don't look at the dentition as, cavity alone. Here you need to identify whether the child, first and foremost, while having a thorough evaluation, the number of teeth present, the size and shape of the teeth present, whether what is the age of the child for that chronological age associated with the dental age, whether the tooth are, as per their nature's timetable. Then after having evaluated this, we check the primary factor, that is presence of any dental decay, dental caries, and of course they are primarily needed to be operated. Once this is taken care of, we need to identify the occlusion, that is the dentation, whether it is parallel on the right and the left side of the jaws. Now, these two joints are so unique in nature that, this is the TM joint, and it is so unique that if I have to open my mouth, both have to function together. So they are structurally two, but functionally they are one. So here it means that if I have to, move my hands, I can do an independent activity. I may not move the left hand, and I may just keep on moving the right hand. But here, when we open the mouth, you cannot say that my right joint is now, I want tired and I want to get it at relaxed, and I open the mouth with the left joint. So evaluation of the jaws and teeth. So after you have evaluated the dentition, you take care of the relation of the TM joints with the upper jaw, that is the maxilla, to the mandible. Now your major factor unidentified or that goes unnoticed by parents is crossbite. Crossbite is something which needs a thorough evaluation. Crossbites means that, the normal posture is the upper teeth are always placed front when compared to the lower teeth. So if you see your dentition as well, all your upper teeth will be on the outer perimeter, and the lower dentition, the lower teeth will be on the inner perimeter. Now, if this relation, whether it's entire segment of the jaw or it's one or two teeth, if that is lost, this is something called as crossbite of the tooth or crossbite of the segment or crossbite of the jaws. There are times where we observe that these kids, most of the times, they, apart from having dental crossbite, they have something called as the skeletal crossbite. Skeletal crossbite is nothing but it means that the lower jaw is forwardly placed when compared to the upper jaw. This needs a very proper evaluation. Some x-rays may be needed, and this is very important for the swallowing reflex. This is very important from the OTPT point of view, wherein they start with all the exercises. So if the jaws are not in place in posture, the functionality of that particular uh, cannot happen. Now, evaluation of the head and neck. This is one of the most important factors when we have to start with certain neurological medicines, or the OTs have to start with certain exercises to identify whether the child is having hypotonicity or hypertonicity. What is the neck posture when the child is sitting? What is the neck posture when the child is sleeping? This gives us very good identifying point whether the child is a mouth breather or is a developing mouth breather, or there are some conditions associated with tricholace or tightness in the neck muscles, because this area is strongly associated with swallowing and the tongue. Dr. Sam, let me know if I'm going a bit fast or
Dr. Vivek, I would probably suggest maybe, we can discuss in terms of improper dentition and the caries and the phases of the phases of feeding.
dysphagia.
Yeah,
Okay.
dysphagia component. I think that would
I'll come to that when I take the tongue, because that's where
perfect.
I,
Uh,
yeah.
so one major thing which I would probably always come across is the proprioception at the TMJ, which you have just mentioned, and the impact of that being really, really high in children in their inability to uh, make a bolus and transfer the bolus to uh, the reflexive pharyngeal stages.
Yes. Okay. So yeah, so the TMJ and the proprioceptive mechanism is very important, wherein the child knows how to first, when the morsel is taken, the child starts crushing the food, mix it with the saliva. There's rolling happening with the tongue, and then it's passed to the second part, or the posterior or the back part of the tongue, and wherein it is allowed to swallow. Now, this is something which um, most of the autistic kids struggle with, and that is when the OT part comes into picture, and Dr. Samraj's therapy has this major component taken care of. Coming on to the evaluation of the lips, uh, most of the times when we see the kids with mouth breathing or incompetent lips, that is, the lips are not closed at rest. So whenever you are at rest, or when your child is at rest, you should be seeing that the lips are completely meeting each other in without a millimeter space in between. So if the child is sitting more so in this posture, or taking support, or many a times the tongue is visible, there's drooling of the saliva. So the evaluation of the lips is very important, whether to identify whether the lips are hypotonic, or they have they have less of strength. With regards to the lips, most of the kids have crust at the corner of the lips, dryness, and when they're sleeping, they have a preference to sleep on the stomach. There'll be saliva on the pillow in the morning, a short attention span. The lips are more of everted out in this fashion, and the lips speak a lot about the oral cavity. Now, coming on, we'll take the lips in conjunction with the tongue because that's where both the group of muscles, fight with each other to place the dental jaws in a neutral zone. So, evaluation of the tongue. Now, this is one major aspect which needs to be evaluated. Uh, the tongue is primarily first site of evaluation is whether there is a tongue tie or not. You need to know whether the child has a tie, which can have a lot of implications on the feeding issues, the speech developments, the neck posture. So, uh, ideally, most of the pediatricians identify whether the tongue is attached to the band of fiber to the oral cavity. But here, what we look at is now the recent classification says whether it's an anterior tongue tie or a posterior tongue tie. And most of the anterior tongue ties are identified well in time. It is very important to identify the posterior tongue ties because the posterior tongue tie is responsible, which prevents the bolus formation, which prevents the tongue from rolling behind in the second part of the pharyngeal stage. So, uh, after having evaluated whether the child is having a tongue tie or not, we also evaluate to the size of the tongue, that is, whether the child is having a macroglossia or a microglossia. Now, most of the tongues are normal in size. Sometimes it may have a relative macroglossia. When I say relative macroglossia, it means that the tongue may appear too bulky or too big in size for the child's oral cavity. Well, it means here that the tongue is normal. It's the jaws which have not grown to its full potential, and that is why it is not having sufficient space for the tongue to be accommodated within the oral cavity. So, if the child is having a bigger size tongue or a macroglossia, does not mean that you start going in for tongue surgeries for reduction in size. It means that you have to have dental interventions, interceptive orthodontics, corrective orthodontics for expansion of the jaws to create sufficient space because the tongue is resting inside the periphery of the upper arch, the upper jaws. Now, when we say that the tongue and the lips, so these are two group of muscles. Now, if you see the teeth, on the inner side of the teeth, you'll have the tongue, and the outer side of the teeth, you'll have the cheek muscles and the lip muscles. Now, any group of muscle should be functioning in balance organization with each other. You cannot allow the tongue to function more and the lips to function less. When there is a disharmony in the balance of the forces acted upon by this group of muscles, it causes the jaw developments, that is the upper jaw, lower jaw, even has implications on the overall face development, and this results in abnormal jaw development. Now, this abnormal jaw development can result in something called as um, you know a crossbite, which is very common with um, imbalance in the muscle fiber strength. So whatever therapy are looked at, it is looked at in a way of tightening the lips and tightening the tongue muscles and bring them in harmony with each other such that the forces acted on each other are equal, so the developing jaws are placed back in the neutral zone. And when this neutral zone happens, the growth itself is the treatment. You don't have to do any active treatment. So here the ot is very important. Whatever the exercises, the ot department, Dr. Samraj's ot program is very intense and very organized. So when they work on the lips, when they work on the tongue, this is very important for placing the jaws in the neutral zone, and with that the opening up of the speech, the resonance, the consonants, the words, the tongue positioning. Now here, when we talk about the tongue positioning, how much so ever OT you do without the tongue being properly postured, without the tongue being having sufficient space. Now the tongue is one organ. Let me give you a analogy that it is the tongue is not attached to the body. In scientific language, we call that the entire body is attached to the tongue, and this is very important. The entire spine is attached to the tongue. So any abnormal posture of the tongue not only affects the oral cavity, it can also affect the hip posture, it can also affect the knee posture. So, at rest, the tongue has to be resting right above the upper two teeth. So, if you just swallow now, and if you have swallowed correctly, the tip of your tongue would be ending right behind your upper front two teeth. And that's where the parking position of the tongue is. So, can you say, if you say the alphabet N, and whatever, if you have pronounced the alphabet N for nest, properly, it means that the tongue is at the parking posture. And if this posture is disturbed, it affects the entire spine and thereby bringing about imbalance in the entire symmetry of the body. Evaluation of the pharynx, soft and hard palate. The first thing that is identified with regards to the pharynx, soft and hard palate after the child opens the mouth is whether there's any kind of a cleft present or not. We rarely see any clefts in autistic kids, but this is one important feature which cannot be missed. After having noticed this, you need to evaluate the soft and the hard palate, the how the palate is structured, whether it is a deep palate or a flared palate. Most of these autistic kids exhibit a deep palate or could be a stared palate as well, which causes a disturbance in the tongue posture. Because the tongue is always adapted, though the tongue is an organ of the lower jaw, the tongue never rests in the lower teeth. If you would have observed your tongue right now, your tongue would be resting right against the upper jaw that is, adapted against the palate. And this major relation is missed upon in most of the autistic kids that we come across. The tongue is taken away from the palate, resulting in a lot of disturbance in speech and sleeping patterns. Apart from this, because the tongue is, the um, palate does not have the stimulus time and again of the tongue, the palate does not develop well. And because the palate does not develop well, it results in something called as a deep palate, a stared palate, or a narrow dental arch. Now, narrow dental arch is responsible for most of the kids having difficulty in eating patterns because when you go about with swallowing patterns, uh, the second stage does not function. The tongue is not allowed to roll behind, and the wave that is formed when the child is eating is lost, and that's where the kids find it very difficult to swallow their meals. Coming on to the symmetry part, as I explained to you that, many a times when we take the history, we always start whether the child was a C-section baby or a normal delivery. Uh, a cesarean child has a higher chances of having asymmetry of the face because it does not pass through the vaginal canal, or no, whether the child has a low birth weight or not, and more importantly, the whether the child was a preterm baby or a full-term baby. With regards to autistic kids, many a times we have data that the kids are, most of them are C-section babies with normal birth weight and a full-term baby. So until the child was 2 years of age, everything seemed okay and everything seemed good. But after 2.5, 3, or maybe, in the preschool age, they were identified as being on somewhere on the spectrum, could be ADHD, attention deficit hyperactive disorder, or short attention span, or full-fledged autism. Um, One major thing that comes here is the gadget exposure, which I think Dr. Sam will take up in his coming up series. But here I wanted to make it a point that gadgets, while the child is eating food, there's a very strong correlation that we see that nowadays parents put on the gadgets to feed the child, and that's where the child starts opening the mouth, but they just stuff or pocket the food and they don't chew it well, and then the entire um, you know circuit completion of making a bolus and everything gets disturbed. So uh, functionality at rest is very important. What is the overall facial profile of the child, whether the child's facial outline is a round or a squarish face, or we start seeing a V-shaped facial pattern. Earlier, when the child is born, he would be having a nice round face until 2.5, 3 years of age. And then as you see the child growing, because of them being mouth breathers and the tongue not utilized with full potential, not postured properly, it could result in a V shape or a narrow facial pattern, typical Fido-Dido kind of a face. So by 6, 7, it's a full-blown Fido-Dido face, and this needs immediate attention. Um, well, with
Uh,
this, we
yeah, Doc. Could you please let us know the impact of the high arched palates and the bruxism, please?
yes. Um, okay. Bruxism is nothing but grinding of the teeth at rest. Now, when we say bruxism, it could be, the child could be bruxing during the daytime, or it could be a nocturnal, that is a nighttime bruxism. To identify the etiological factors of bruxism, we have more than, you know, 40, 45 etiological factors, one of them primarily being a working mother, and also very commonly associated with deficiency of magnesium. There are many other factors, but they are evaluated only in the operatory. These are two major factors that can be attributed here. Well, with regards to high arch palate, what we have observed or how it happens is there's a direct proportion between bruxism and the high arched palate. The more the deeper the palate gets into, the more the child starts bruxing, and this is mainly because of the deep palate or the high arched palate. The tongue is not postured up against the roof of the oral cavity, and that's where the child struggles to articulate the teeth. Now, this mechanism is lost when the tongue is not postured. Now, just imagine this is your upper molar, this is your lower molar, and they are articulating with each other. They are having nice interdigitation. Now, when this balance is lost because the somewhere in the oral cavity here, the tongue is not postured well, it is trying to identify where it has to be resting. So that's where the the teeth start grinding each other, and then they become flat. That's because the teeth want to organize itself, or conjugate, the lower teeth want to conjugate in the upper teeth so that it can allow the function of deglutition happening. Deglutition is nothing but the swallowing pattern. One important thing that I was mentioning here with the symmetry and functionality is at rest is whenever the child makes a swallow reflex. Not I'm talking about passive swallow, that is swallowing of the saliva. We're not talking about swallowing of food at this point in time, or the liquid. Swallowing food is very easy. Swallowing a liquid like water or a juice, milk, is very difficult. Swallowing liquids is difficult when compared to swallowing of solid stuff. So when we talk about passive swallowing, that is, I have just swallowed right now. I've swallowed the saliva. Now, when I've done this, did I make the muscles of facial expression participate? Did I do something, or did I put in efforts where I'm utilizing the lip muscles, the cheek muscles, or the muscles of the facial expression, or the muscles surrounding the eyeballs? No. When we are swallowing normally, it is only which starts at this point and gets down, without any. So this parents can identify very well that whether the child is putting in an effort or not. And then you can start identifying at what type of food the child is putting in an effort for swallowing. So you can take up this as a very important test where swallowing is associated with. Also, with regards to bruxism, bruxism is also associated with mutilated teeth or mutilated dentition. Now, that's what I explained you right now, that the upper and the lower teeth would like to conjugate with each other. Now, if there's a dental decay, if there's a cross bite, if there's any um, you know, if there's a filling done for your child and the filling is not done following the normal anatomical pattern and there's a high point in the filling, then as well the child would start want to brux and get the conjugation. So you'll see bruxism happening very common. Uh, we have parents complaining that a change in environment or change in the child's pattern, bruxism has increased. Yes, bruxism could be associated diurnal, bruxism could be associated climate as well, but it is just a transient thing. If it's normal, it could be for a day or max for a week, but something which happens on a daily basis where the child is just continuously grinding and you can hear the voice. Or even, there are parents who say that even if we are in the other room, sometimes we can hear the child at night bruxing, and it's quite traumatizing to hear that. Yeah. Um, just a moment.
Yeah, Dr. Vivek, thank you for that. But
Yeah.
I do have few more questions for you. Like what I've seen most of the times is that getting these children to a dental clinic in itself is a big challenge, and to
Mm-hmm.
make them undergo the procedures or get them adapted to be uh, going through that long process is a challenge. So how do you usually manage that out in your clinic? Or what
Well,
would
ours
be
is
your suggestions for parents? I mean, how do we prepare a child?
okay. This is you're talking about any specific medical condition or a general one?
Autism.
Okay. So when we talk about autistic kids, don't over prepare the child. Don't explain or don't try to implode a lot of stimuli that they may not like it in the dental operatory, because you as a parent may be trying to explain them good, but the experience could be this or this or this. Now if the experience is this, the child accepts it well, but if the experience gets a little different from what you have prepared the child at home, it gets difficult for the child to wash off the memory and accept new things. All you can explain the child or teach the child as a dentist who's a friend for the teeth, and he's going to count the teeth. So you start counting the fingers at home, start and then after a day or two start counting the teeth at home. Or you can put in a spoon in the oral cavity and say, can I see the teeth on this side? Can I see the teeth on this side? And leave it over there. Don't overdo things. Allow the dental clinics, the pediatric dental clinics are the best to take care of them. They know how to accept each child. So our clinic is 100% inclusive clinic. So whether it's a CP child, an autistic child, Down syndrome, or any syndromic child, we adapt. We don't rush with the appointments. We don't rush with our consults. We give as much time the child needs before the child wants to settle on the dental chair. Now, once the child is on the dental chair, it starts with, giving them your gloved hands, allowing them to feel, giving them the mirror in their hands, and then hold their hands and then open. So yeah, it is important. General dental clinics will not be able to take care of this. It's most of the pediatric clinics can help you with this, and it has to be an inclusive clinic, wheelchair accessible primarily, and more important, one appointment at a time. The child needs his own space, his own time. Now, how do you prepare? Is I've told, don't over prepare, don't do too many things wherein, you may not have those stimuli of air and water at home. And when it's introduced, the child does not like it because he was prepared something else at home. So all you can prepare is opening the mouth in a mobile torchlight, putting the spoon, mimicking it as a mouth mirror, giving him a lot of stimuli around the perioral areas. So when the child is on the dental chair, we don't touch the oral cavity immediately. We give them our gloved hands, ask the child to hold, and when they hold, they like it. Sometimes they would not like the latex smell or the latex fingers going into the mouth. So we have flavored gloves, and at times we ask the parents, the child may like some kind of flavor. So depending on that, we use mouthwashes rubbed on our fingers, gloved hands, and then we introduce. So they usually accept it.
Uh, that's really, thank you so much for that input, Dr. Vivek. And I do have one more question where
Yes.
pertaining to the treatment protocols and treatment procedures, because many of the kids, because of excessive pocketing and dental caries, I see most of the dentists prefer fluoride treatment versus root canal management. So, what you would be suggesting parents on that?
Okay. Let me add a point before I answer this. So when we talk about treatment protocols, what we have observed is parents want to generalize the treatment. Now, most of the parents have, support system, WhatsApp groups wherein they talk to each other, exchange ideas, and it's a beautiful way of, a mother understands a mother. So it's easy, only when you discuss with someone who has gone through that journey. But that does not mean that, the other child was given a particular treatment protocol. It becomes a generalized pattern for every child. Each child, whether it's a dental treatment, skeletal intervention, OT, or oromotor therapy that we usually advise, is not cut, copy, paste. It has to be tailor made. Now, when we talk about fluoride versus root canal treatment, parents need to understand that root canal is something that the canal system in the tooth is got disturbed, and the nerve in the canal system is inflamed. It is raised with a lot of pressure, and that is why the child is complaining of pain. So root canal is to take care of pain and infection, and after the root canal is done, the crown is to give back the function to the tooth. Parents feel that root canal is done, so we may not do the cap. No, you have to do the root canal to take care of the pain and infection, give a crown to give back the function. And when it comes to fluoride, fluoride is a preventive measure. It is not a corrective treatment. Fluoride is done for healthy teeth. Fluoride is done for teeth which do not have dental decay. If you say that my child needs dental treatment, but I would like to do a fluoride, thinking that fluoride will help my child, no, it will never help. Once the decay has set in, you have to have corrective treatment for that particular tooth. Fluoride, even if you do every day, in office fluoride every day, the max, it will not even help 0.0001%. Fluoride is done on a healthy tooth. So let me explain you. Fluoride, you know, the tooth is made up of hydroxyapatite enamel. The outer layer of the tooth is something called as, chemically or technically called as, hydroxyapatite. Now, when we add fluoride to the outer layer of the tooth, it chemically reacts with hydroxyapatite and gets converted into fluorapatite. Now, it is this fluorapatite which is resistant to dental decay. So, a tooth which hydroxyapatite is already affected, and now you add fluoride to it, it's a mutilated hydroxyapatite. So a mutilated hydroxyapatite cannot be converted into fluorapatite. You need to have healthy enamel for fluoride to function. So fluoride is very essential. Fluoride should be done, and fluoride is mandatory. I advise every child walking into our operatory to get 2 cycles of fluoride every 6 months to start with. And once you have taken the child into the zero cavity club, then you can do once a year. But as long as the child is having a cavity, biannual, semi-annual, or twice a year is very important. So fluoride cannot be attributed as a substitute to root canal.
Thank you so much, Doctor, on that. Uh, so, parents, what I really want you to understand here is feeding, as such, as I mentioned, is just not an act of getting a child to eat. Before you actually get a child to eat, you need to be really aware of the structural factors or structural abnormalities what child is going through or what is stopping the child. Unless and until that is not been looked into, don't really force your child, because I've seen many of the parents in lines of kids having concerns with dental caries, but they will be forcefully feeding them. Just please imagine, uh, just take a call like this. I really get a lot disturbed even if a small substance gets occluded between my teeth. Unless and until I don't remove it, it keeps nagging, it keeps disturbing and irritating me throughout the day. So just imagine what the kid might be going through with a dental carie or an issue with the dental concerns or the structural abnormalities, and we are really forcing them to eat. So it's very important for all of you to understand that what comes first and how you need to go about intervening so that the child becomes completely independent, because feeding as such comes in phases. We say that we talk about the preparatory phase, we talk about oral phase, we talk about pharyngeal, and we talk about esophageal phases, which few of them are voluntarily being done, and few of them are done involuntarily, like reflexively, like especially your pharyngeal and esophageal phases are most of a reflexive thing. So for a reason like your gastroesophageal reflex disorder, GERD, one of the most typical concerns, or your gag reflexes, they're all reflexive patterns. So it's not, as I mentioned, it's just not about feeding as an occupation, but you need to look feeding as a whole. Where what are those internal factors which are affecting the child? What are the environmental factors which are affecting the child, which is making the task of feeding difficult for the kid and difficult for you and challenging for you too. So it's very important, I would say. Dr. Vivek, can you throw some light on probably what are the phases of oral rehabilitation in case if there is any structural limitations for the kid?
Okay. I just wanted to add one more point to your part
Mhm.
of discussion. Um, when we say about all this parents force feeding the child and wanting the child to start, eating, what is, why this orofacial evaluation is important is to identify what shape and size of the spoon has to be introduced. Let's put it in that. So in a gist of one line, orofacial evaluation is very important so that your clinician can identify what spoon you can introduce for your child. Now whether most of I had a parent using a regular spoon, but the child's palate was so deep that you enjoy an ice cream, just leak out an ice cream through a spoon, or you take a good bite of your favorite food. You want to clean the spoon as it comes out. So that's where the spoon is getting adapted according to your tongue, your oral structures. The dessert spoon or regular spoon, when you feed yourself, you find that while eating maybe a spoonful of rice, and the same amount of rice, if you want to eat, you cannot use it with a small size spoon or a dessert spoon, and vice versa. Now, I had one parent wanting to feed the child, and when I asked the parent to share a small clip of how is the child being fed, the child, the parent used to take the spoon, a puree diet, of course, a big size because the child would not swallow well. So the parent thought that taking a mouthful of spoon will allow some food to go inside. But if you're taking a big size spoon, you're allowing the child to spit out more food. If you're taking a small size of a spoon, the child has room inside the oral cavity wherein he can process the food. Now, this parent was putting in the food on the sides with the spoon, directly on the molars, and expecting. So, what the parent thought that since the child is not able to grind or use the teeth or churn the teeth, the molars one above the other, the parent thought taking the spoon and putting the food directly on the molars, thinking that you're just putting it in, in the grinders just where the blades are. No, you don't aim the food at the blades in the mixie. You just put it inside entirely, and that's where it starts running. So this was one thing which, the entire talk today placed why orofacial evaluation is to identify how do I start, where do I start, what spoon to use, when to introduce a fork, what length of the straw to be used, what diameter of the straw to be used. These are so much important things when you do OT. I think you do one of the best jobs of OT because you guide not only with the type of food, but also what type of spoon, the diameter of the, there are times when parents buy a huge water bottle with the entire length of the straw and expect the child to suck the liquid. Uh, you cannot expect someone who is learning to suck because the lip muscles are not developed, the tongue is not rolling back. So you have to identify the length of the straw as well. The child will be able to suck the liquid, the juice or the water maybe for a 10 centimeter straw. But if you get something which is a 20 centimeter water bottle and ask the child to suck the entire length, it puts in a lot of effort and stress, and then they want to give it away. Yeah. Can you come again with the question that you just hit me?
No, Doc, I
The
was
last one.
sorry.
The last question you mentioned, the treatment plan, or I just missed. I took
No,
up that
I was
point.
just asking you like what would be the oral rehabilitation stages from a dental perspective?
Yeah, I wanted to answer this rehabilitation stages. Okay, so oral rehabilitation stages. Now, again, I will answer this with regards to the talk today, orofacial evaluation. So, our stage one or the primary stage would be preparing the child to accept the dental treatment. So this stage is so important that, in this we would take up simple procedures like cleaning and fluoride, wherein the child understands the stimuli coming into the oral cavity, uh, how to sit, how to behave, and all those things.
Uh, I I would request
Yeah.
all the parents to mute themselves, please. Sorry, doctor.
Yeah, so that is the stage one. And then we come on to the dental stage. So I would take up as stage two as a dental stage, wherein we do the entire correction of the mutilated teeth, the jaws, or wherever the dental decays are there. So stage one would be the preparatory stage, wherein the child is given a chance to understand the dental stimuli, that ways by way of doing dental cleaning and fluoride. The second stage is the corrective stage, wherein we take care of all the fillings, the root canals, the caps, and all those things. And then comes the interceptive orthodontics, wherein we take care of the tongue ties and the cross bites, the bruxisms, the arch developments, expansions of the jaw bones, and all those things. And then comes the oromotor therapy. So after you have done the structural correction, that is in the stage three, it is where your OT and PT can make wonders. You want to just keep running with the correct pair of sports shoes, or You just want to do the activity, you want to build up your muscles, you want to build up biceps, but without having dumbbells, it cannot happen. So you have to have the structural correction happen, which is happening primarily. So stage one was preparatory stage. Stage two, just to reinforce, stage two is the corrective stage wherein we correct the uh, teeth. Stage three is the tongue ties, the jaw bones, the cross bites, the arch expansions, the narrow palate, the mouth breathing, the tongue thrusting, the swallowing, the bruxism, and all those things. That is clubbed as interceptive orthodontics. And as you initiate the interceptive orthodontics, we ask assistance of you to help us with the OT, OMT, PT. So we cannot function. So whether it's my department or Dr. Sam's department, it cannot function individually. It has to have assistance. So just at the correct start of the interceptive orthodontics, you have to introduce the speech and the OT simultaneously. You cannot say that now I will allow the tongue to settle down with my therapy and then I will take it up. No, as it has started expanding or as the tongue is started released, immediately you start with your speech and OT. So that really helps because immediately you take away the abnormal growth, or you take away the hindrances in the path of natural growth, and growth itself is the treatment. And of course, with great assistance with the OT and speech, I cannot work interceptive orthodontics without OT and speech support.
On the same lines, I would really like to highlight this to the parents. Please understand that it's not always OT, or it's not always the speech therapist, or it's not feeding therapy or tongue placement therapy or your SOS therapies. It's you need to really look in terms of a holistic approach whenever you are dealing with a child with feeding. And the reason why we started with Dr. Vivek was because that's the very first step which is required for you before you actually bring a child to therapists like us to intervene with the feeding concerns or the development of speech or language issues. So please try to understand child as a whole, and the motive of basically the motive of these sessions is to educate or to empower you with knowledge of where you need to be starting rather than looking at the end act of feeding. The challenges what child might be having in terms of their inability to uh, become independent in feeding. The first step what I want you to really look at it is how is their orofacial structures, anatomically how are they placed, is there any concerns which are like what Dr. Vivek has said, hindering the child or inhibiting the child so that he can become completely independent in that act. So please, I'll be taking it forward basing on what Dr. Vivek has spoken now on each and every component of this and how that would be affecting feeding as such from an occupational and from a speech therapist perspective. I'll be going more deeper from our line of management in coming webinars. And Dr. Vivek, I think there is one last question which has come up in the chat for you. That Dr. Rebecca wants to know, what are the common management strategies that pedodontists commonly adopt for children with mixed cerebral palsy, especially in light of their oromotor challenges and associated feeding or oral hygiene difficulties? I'm guessing, Dr. Rebecca, probably you're talking about the fluctuating muzzle tones, or is it something related to the postural concerns or the feeding concerns, Dr. Rebecca? Because
Yeah,
most
thanks, Dr. Samraj. Actually, I could follow the discussion, although I'm naive to this area. Being an optometrist, I have no idea about all of this. It's a nice learning session for me as well. So, actually, what Dr. Vivek had highlighted as part of the stages of rehabilitation, that actually threw light on this question. So, essentially, I was looking at where would this fit in, even in otherwise also, not a specific case, otherwise also how it would be. So, I think, yeah, it kind of answered my question. Yeah, thank you.
Oh,
I would
perfect.
like to add, Dr. Rebecca, that when you talk about management strategies, also ask your pediatric dentist to talk to your OT and speech therapist once while formulating the treatment. It really helps, like, when we work as an interdisciplinary, like I work with Dr. Samraj, and any case referred to us or vice versa, we after the evaluation we usually discuss, because there are times when some points are missed by the parents or picked up more so by the clinician. It helps in designing or customizing the program for the needs of the child. At times, I know it's a very stressful thing for parents to visit, time and again for consults, but there have been one or two instances where especially with cerebral palsy, I have asked the parent to visit, go back, and then we start with the treatment or the preparatory treatment in the third appointment. uh, the child needs to understand the environment. So we never, push, or we never advise, even though parents come from far off, they say, why don't we start it today? It's not what you or I want, it's what the child wants. So we believe in giving the child the space to understand the environment, to relate to us. So even if you come for the second appointment as a consult, the child meets us, goes back, his apprehension comes down every time he walks into the dental operatory. Now, if the child has come in the first visit and we start with any procedure the parent wants, the next time the child will panic when he enters the same premises. So one or two visits are very important for the child to just come, meet, go. So by the time they come to the second and the third visit, even if you're going to take a root canal in the third visit, they have calmed down when they enter. They know that this is a place where they belong to. This is the place where, I will be given some time. And they don't enter with anxiety. They don't enter with anxiousness, apprehensions. They come in calm, they settle on the chair, and then slowly you introduce the stimuli. Of course, it's not easy, even in the third appointment, but it really helps the child prepare mentally. So when you talk about CP kids, that's one point I, wanted to add on.
So
Thank you
Rebecca,
so
just
much,
to
Dr. Vivek.
Yeah, just to
Yeah.
add on to what Dr. Vivek has said, from the Otis perspective, we look a lot in terms of the tone, the muzzle tone of the tongue and the cheeks, and how the patient's head and neck is being positioned before actually getting them to feed. Because most of the time, a lot of the lot of the therapists, or in many of the practices, what they miss out is a child with CP would be having many of the primitive reflexes not being integrated. And they really don't work on that, because if you're not really looking in terms of addressing the primitive reflexes, sometimes it becomes very difficult for transition of food. From puree to, I mean, liquids to solids, or from purees to semi-solids. So it's very important to actually, before getting the child to eat, like what Vivek has said, uh, probably I look into the kind of spoon also what I'm giving, or probably the kind of straw what we are giving the child. Because most of the times I see in many of the facilities, usually they hyperextend the neck. Usually they make the child lift their head while feeding, but actually that in itself is one of the major debacle, because chin needs to be tucked in if the food has to go without any aspiration. Because that probably, the structures, the oral structures in itself, will become a better placed if chin is tucked in comparison to neck being hyperextended. So there are very small factors which actually matters a lot when we are talking about feeding. Mm, Probably we'll pitch in more into that in the later stages. As the series continues, we'll talk about all those factors, and I would encourage parents, if they have any last few questions, they can come up with those questions so that Dr. Vivek can answer all of you.
To add on what Dr. Samraj just rightly said, imagine the way you feed your child, the same postures, first try feeding yourself. Can you feed yourself when the flight is taking off? So that's where you extend the neck and then you feed. No, whether you are in a flight or you're on a cruise or you're at home, when you take the spoon, the first act that you do is you take your head forward. So uh, that was something which you as parents need to identify, that how my child is going to do it if I'm not able to. So that's a query. Some children don't like to have fruits and pulses. How can we train them?
I would take it out in my sessions when I talk about sensory processing concerns, Doc. I would be definitely happy to address that, ma'am, Mr. Vetri. That comes in the later session, so we would definitely take it forward. That question would be answered by me in the later stages, and we have created, along with the Dr. Vivek and other specialists along who are there with us, we have created almost around a 20-25 page.
Dr. Sam, I think everyone has lost connection with you. I'm not sure. Hello?
Audible?
You're audible now. I think there was some, when you mentioned that you have developed a 20-25 page questionnaire, I think post that there was some error in hearing. I think we've lost connection with stars. Just a moment.
Hello.
Yeah, you're audible now.
I'm really very sorry for this confusions because we are having a little bit of storms going on outside, so the connections are pretty much unstable for us.
Mm-hmm.
But in any ways, we are going to send uh, we are definitely going to send to those parents who send me an email. We'll send this evaluation sheet for all of you. So just try to fill it. That will make you understand where exactly your child is with the different concerns. And probably down the line, when we are going to keep talking about these topics, it becomes easier for you to intervene the right way with your kid. And I would like to actually thank Dr. Vivek for giving me such a your time means a lot, I know, Doc, and thank you for giving it. Though it's been, I think, 5 or 4 o'clock in the morning for you. You have been considerable enough to accept our invitation. Thank you so much for that. And I would like to thank Shravani ma'am for hosting both of us together from Superstars, and hoping to see you, Doc, pretty soon.
Yeah,
I'll give
sure.
the platform to Dr. Shravani ma'am so that she can take it forward from there.
Thank you, Dr. Jagani, for the in-detail explanation of orofacial evaluation. As a mother, I learned a lot how to feed my child. Thank you. I once again thank you so much for joining this webinar. And I
Thank you so
also
much.
request all the parents, if you guys need any in detail explanation or evaluation, please send us an email to our clinical director, or if you need an appointment with Dr. Vivek to evaluate your child further, please send us an email to us so we can help you in the process of getting an appointment with Dr. 𝐒𝐿𝐥𝐞𝐫 too. Thank you all, one and all, everybody who joined this meeting. Please keep joining these meetings that we are going to conduct every Saturday. And we will keep discussing and we'll keep educating all the parents about the challenges you're facing every day in your journey with your kids. Thank you so much.